In this lecture, we will discuss infectious diseases as part of our general and oral pathology course, but there's also going to be a lot of microbiology that accompany this topic, so you're going to want to pay attention to those microbes because you're probably going to see them on your national board exams. You're going to want to know which ones cause which disease processes. This lecture is going to be split into two parts. Part 1 is going to cover bacterial and fungal infections, and in part 2 we're going to focus on viral infection. The first thing we need to talk about though before we dive into these different disease processes is what it means to have an opportunistic infection. It's important to understand that many of these diseases do occur opportunistically. Opportunistic infection just means that the microorganisms that do not ordinarily cause disease can become pathogenic under certain circumstances. So what type of microorganisms are we talking about? Well, viruses, bacteria, fungus, and protozoa. Opportunistic infections happen more often and with more severity in people with immune system weakness. So remember, we've talked a lot so far in this course about making sure that we are not providing treatment to patients who are immunocompromised without first getting a med consult. Hopefully today that's going to bring these issues even more into focus for you. So what can weaken a person's immune system? Well, a number of things. Smoking can, not that they are so immune compromised that they need a med consult, but it can weaken their immune system. Taking certain medications like chemotherapeutic agents and immunosuppressants in those types of patients that we know they are immunocompromised because of their medications, those are the ones that we want to make sure we get a med consult on. But even poor nutrition can weaken someone's immune system. So when we have changes in salivary flow or antibiotic administration, those things can change the normal microflora that cause organisms that don't usually become pathogenic to become pathogenic and cause disease. We're going to talk about one of those conditions today. Examples of opportunistic infections would be oral thrush, just normal biofilm, strep mutans. There's a whole lot of things that can cause infection where normally in a healthy person you would not see those things. So we've already talked about the difference between inflammation versus immunity, and if you need to review that, go ahead and go back and review the lectures for chapters 2 and 3. Once a microorganism enters the body, our inflammatory and immune response mechanisms identify that microorganism as a foreign substance. Our inflammatory response, though, is not very specific, so it can lead to a large number of neutrophils and macrophages at the site, and if you remember correctly, those can cause edema and more infiltration than neutrophils. They can leave behind some damage. But our immune system, though, is highly specific. Antibodies are formed in response to a specific antigen, and our immune system recognizes that and attacks. So feel free to review my previous videos from chapters 2 and 3 if you need a more detailed description of the difference between inflammatory and immune response. The first disease that we're going to talk about, I actually mentioned in another lecture when we were talking about how to describe lesions, and I think I used impetigo as an example of Ebola. But impetigo is a bacterial skin infection, and it's usually seen in kids, and it's caused by Staphylococcus aureus, in combination with Streptococcus pyogenes. So Streptococcus pyogenes. We all have these pathogens on our skin, but once a cut or a break in the epithelial layer occurs, they like to take the opportunity to cause infection. The lesions of impetigo are highly contagious, so direct contact with those lesions should be avoided. The lesions can present as vesicles, or they can be larger bulla in some cases. But those lesions are going to rupture and leave behind a crust. They may itch, there might be lymphadenopathy, but fever is not usually present. Now, if these lesions are around the mouth, they can be confused with herpes simplex virus because of their vesicular appearance. Diagnosis is made usually by clinical presentation or by culturing that bacteria. And since it is bacterial in nature, it is typically treated with topical and or systemic antibiotics. A lot of kids end up having impetigo at one point or another during their childhood. The second organism we're going to talk about is Mycobacterium tuberculosis, which is the bacteria that causes tuberculosis. While this disease is primarily considered a lung disease, tuberculosis can affect other organs like the kidneys and the liver. Tuberculosis is also highly contagious, and it's usually spread by the inhalation of droplets that contain that bacteria. We're going to learn a lot more about tuberculosis when we study diseases of the lungs in another course. So today we're just going to focus on the basics for this lecture. Oral manifestations of tuberculosis are rare, so we're really just not going to go into depth on that. Just know that they can have oral manifestation. But most of us have had a screening test for tuberculosis where they prick you. They actually inject an antigen under the skin, and then if you react to that antigen, then they will do a chest x-ray to give a final diagnosis. Now, patients who have a history of tuberculosis need to be very thoroughly questioned on their medical history. Well, what kind of things should we be asking them? When were you diagnosed? What type of treatment did you receive? Have you had a recent cough? See, a patient who's had tuberculosis should be a very good historian, and if they're a poor historian, then our radar needs to go up. What do I really mean by that? Well, if the patient can't remember when they were diagnosed or what treatment they received, they're a poor historian. So if you say, okay, well, Mr. Smith, when were you diagnosed? Oh, sometime maybe 10 years ago. Okay, did you receive treatment for your tuberculosis? I just don't really remember. Let me tell you, these patients would remember. It is a 6 to 9 month, very intense antibiotic treatment, and it makes them very sick. It'd be like saying, oh yeah, I think I had cancer and I had some chemotherapy, but I'm not sure. Not to compare the two because it's kind of apples and oranges, but a patient who has a significant disease process should have a lot of memory about being treated for that disease process. Now, if the patient has been cleared, a lot of times they will carry paperwork from the health department that they have been treated and cleared, not cleared, but that they're no longer contagious from their tuberculosis. Anytime a patient says that they have a history of tuberculosis, we're going to stop and we're going to get a med consult just to be on the safe side. Actinomycosis is caused by this bacteria. Why am I not saying it? Because it's so difficult to say, and I've already tried to say it about 5 times and had to erase each recording. So I'm just going to display it on the screen there for you. Although it's unclear why this bacteria causes disease, it's often preceded by a tooth extraction or some type of abrasion in the oral mucosa. So you're going to have a manifestation of an oral lesion that's going to drain by formation of a sinus tract. Remember, when I say a lesion is draining by formation of a sinus tract, that means that it's finding the path of least resistance through one of those sinus tracts to try to get out. They have a characteristic tiny bright yellow grain, which are called sulfur granules. The diagnosis of actinomycosis would be made by identification of the bacteria under the microscope, and then it would be treated appropriately with antibiotics. Now, here is your first board alert for this question. You may also see this condition referred to as lumpy jaw. Lumpy jaw. That's because the way that it presents typically has a huge swelling on the jaw that has an exterior draining from that sinus tract drainage. Syphilis is caused by Treponema pallidum. These guys are spirochetes, which means that they have a corkscrew appearance. Syphilis is transmitted by direct contact, usually through sexual contact with a partner who has an active lesion. So this disease occurs in 3 different stages. We have primary, secondary, and tertiary. In the primary stage, the patient would present with a canker. So here in this picture, you can see the patient has a canker. During this stage, the canker is highly infectious and it has formed where that spirochete has entered into the body. Now, if untreated, this canker will heal within several weeks and enter a latent period. That's going to give the patient a false sense of security that whatever condition they had has now healed on its own. But that's not what happens with syphilis. The secondary stage occurs about 6 weeks after the primary lesion. In the secondary stage, there are diffuse eruptions of the skin and mucous membranes called mucus patches. The lesions in the secondary phase are more contagious than those in the primary stage. They can undergo periods of remission and recurrence for months or years. Then it will enter eventually into a tertiary stage. Tertiary just means third, by the way. We have primary first, secondary second, and tertiary third. So in the third stage, which is years after the initial infection, we can have a presentation and issues with the cardiovascular system and the central nervous system. And the patient can develop lesions called gumma. While gumma are not infectious, they are very destructive and they can lead to perforation within the body. So there's been a lot of advance in treatment of syphilis over the years. In 2014, a rapid finger prick test was developed, but it can produce false negatives, so sometimes you have to get retested. But the thing about syphilis is it's easily treatable with penicillin. So if people who had syphilis in that primary stage would just get treated then, they would not have any long-term effects from the syphilis. Necrotizing ulcerative gingivitis is often referred to as NUG, but you're going to hear a lot of people say ANUG because for many years this was known as acute necrotizing ulcerative gingivitis. So some of us who've been around for a while will inadvertently call it ANUG. I catch myself saying it all the time. There is another variant of this called NUP, which is necrotizing ulcerative periodontitis, but we're going to learn about that in perio class. If you've had a patient who's presented with NUG, you won't forget it. The smell of this condition will permeate the entire room. It's a very painful necrotic condition of the inner dental papilla. This condition is caused by a combination of fusiform bacillus and a spirochete, Borrelia vincentii. The patient may complain of a metallic taste, fever, lymphadenopathy, but we would have a characteristic punching out of the inner dental papilla. With these patients, we'll typically start them on an antimicrobial rinse, chlorhexidine, prescribe an antibiotic, and then we'll bring them back for a debridement once we've gotten that bacterial count down and that pain under control a little bit, enough for them to tolerate what we need to do. Usually we can diagnose this condition just based on the oral manifestations. The punching out of the papilla with the smell of the condition is pretty telling. I have seen this many times in my career, and you just really never forget it once you've seen it. Pericoronitis is a really good example of an opportunistic infection. Pericoronitis is an inflammatory condition that happens when a partially erupted tooth will allow for a breeding ground of bacteria. We see this really frequently with mandibular third molars that are partially erupted, where the gingival flap is still remaining over the distal end of that tooth. This is going to allow for normal oral flora to proliferate and cause infection in that pocket, when normally the oral flora would not cause an infection. This condition is pretty common, so we're able to diagnose based on clinical appearance and symptoms. We would just irrigate that area, prescribe antibiotics, but eventually we're going to have to take that tooth out, or it's just going to proliferate again and another infection is going to recur. Osteomyelitis is basically an infection of the bone, which can be acute or chronic, but it is a very serious condition. Acute osteomyelitis is usually the result of a bacteremia or a fracture or surgery of the bone. The patient would present with pain and possibly lymphadenopathy. This is a very destructive condition which results in rapid loss of bone. Microscopic examination would reveal necrotic bone, so dead bone, inflammation, bacterial colonies. Anytime a patient is suspected to have osteomyelitis, they're going to be referred to the oral surgeon. And the oral surgeon can debride that necrotic tissue, drain out any of the exudate that has accumulated, and prescribe an appropriate course of antibiotics. These patients are going to be followed along very closely. If an acute osteomyelitis is not treated thoroughly, it can become a chronic condition. Chronic osteomyelitis can occur with diseases like Paget's disease, sickle cell anemia, with bone that's been irradiated, and more recently, there's been an association between patients who take bisphosphonate medications for osteoporosis and the development of osteonecrosis of the jaw. So on a patient's medical history, a lot of offices will ask specifically if the patient is currently taking or has taken bisphosphonate medications. These medications like Fosamax, Reclast, Boniva, when these are taken in a pill form, they're usually not a reason for concern. However, patients who are undergoing chemotherapy may have infusions of bisphosphonates, like Zometa, and they are at a higher risk of osteonecrosis of the jaw. So in that case, if the patient is receiving IV or infused bisphosphonates, we would want to have a medical consult prior to providing invasive care. The treatment for chronic osteomyelitis is the same as that with acute osteomyelitis. Okay, now we're going to move into a section talking about fungal infections. Fungi are obligate aerobes. What does that even mean? It just means that they require oxygen to grow. Fungal infections occur in the mouth all the time. You're going to see a variety of fungal infections in your career. The first one we're going to talk about is a pseudomembranous candidiasis. With pseudomembranous candidiasis, there's going to be a white, curd-like material present on the mucosal surface, and the underlying mucosa is going to be very erythematous. The patient is going to have probably a burning sensation. They may complain of a metallic taste. Now, this is the second time that we've had a condition which may result in a metallic taste. So right now, I want you to take a minute, look back at your notes, and see what condition we discussed earlier in this video which may have a metallic taste. Okay, moving on to erythematous candidiasis. With this one, the patient will have a painful erythematous mucosa, which may be localized or generalized. When they have this on the tongue, we would see an irregular, patchy depapillation, which could easily be confused with geographic tongue. So we have to go back to which one is the more likely condition. Are there signs and symptoms that would associate this with a fungal infection? Is the patient immunocompromised? Or have they had these patchy depapillations their entire life? Well, most of the time, the patient will say, oh yeah, I've had this for a long time. We can easily narrow that to geographic tongue. So remember our theory of Occam's razor. Denture stomatitis is a candidiasis infection that you're going to see regularly in practice. This is a form of erythematous candidiasis, but the erythema is going to follow an almost exact outline of where the denture or partial is covering the mucosa. Most of the patients that I've seen who have this, and it happens a lot, they're unaware that they even have a candidiasis under their appliance. So sometimes if you can take an intraoral photo, that's a really great educational tool to help the patient understand the proper cleaning of that appliance, and maybe letting their tissue rest for a little bit would be helpful in clearing up and preventing the recurrence of the candidiasis. Now, if the patient has symptoms of that erythematous candidiasis, then we can provide them some medication to rapidly reduce that fungal infection. Otherwise, if the patient would just clean that denture really well and let their tissues rest, it will probably clear up on its own. Chronic hyperplastic candidiasis is also called Candida leukoplakia or hypertrophic candidiasis. This type of candida, unlike the others, the white lesion will not wipe off. So normally with candida, if you take that white plaque-like substance, it's going to wipe right off. But in hyperplastic candidiasis, that white lesion will not wipe off. However, if we treat a leukoplakia that we suspect to be candida with an antifungal, it will disappear. So this would be a great example of a therapeutic diagnosis, because if we provide therapy and the therapy works, then we know exactly what that condition is. If the lesion does not respond to the antifungal in a short amount of time, then a biopsy should be recommended. This example is a good one because it could easily be confused with linea alba. So when we have a case study, as I've already mentioned, we want to look for clues that lead us in the right direction. So if we follow that theory of Occam's razor, while you may have a variation of things on your differential list, you're going to go with the most likely cause. So in order for us to narrow our diagnosis to chronic hyperplastic candidiasis in this case, we would need extraordinary evidence. So if a case study doesn't mention anything about clenching and grinding, but says that the patient is immunocompromised and that the lesion disappeared after a 2-week treatment of nystatin, that would be pretty extraordinary evidence of chronic hyperplastic candidiasis. So follow your clues when you get those case studies, and it can be more than one thing. Angular cheilitis is another condition that you're going to see frequently. We see this in the labial commissures in patients who have a downturned mouth due to loss of vertical height, usually as a result of wearing a denture, and they lose that vertical height and it causes the corners of their mouth to turn down, and the saliva will pool in the corners of their mouth. Angular cheilitis, though, can also be the result of a nutritional deficiency or a combination of nutritional deficiency and candida. This condition will create a burning at the corners of the mouth, and it makes it painful for the patient to open due to the stretching of the lesions. You can see that they can become very cracked, they can bleed. So since fungi like to breed in the dark, chronic wet environments, the corners of the mouth make for a great breeding ground. So anytime we see angular cheilitis, we have to think either this is a candida infection, a nutritional deficiency, or a combination of those two things. A severe form of candidiasis that can occur in patients who are severely immunocompromised is called mucocutaneous candidiasis. This would include a combination of pseudomembranous, erythematous, and or hyperplastic candidiasis and angular cheilitis. So it's going to involve the skin and the nails. There's going to be more than just one location involved in this type of fungal infection. Median rhomboid glossitis is one that you're already familiar with. So it is called central papillary atrophy. This will appear as an erythematous, often rhombus-shaped, flat to raised area on the midline of the posterior dorsal tongue. Some studies show a connection between median rhomboid glossitis and candidiasis, but there's not conclusive evidence. It's enough, though, that we want to mention it in our study of fungal infections. Sometimes these lesions will respond to antifungal medications, and sometimes they do not. Most patients, I have seen this a few times in my career, and the patients were unaware that they even had it, so it's asymptomatic. The book lists several examples of deep fungal infections. You don't really need to know the names of those particular infections for what we are learning. Just know that deep lung infections can occur and they can display oral lesions. The oral lesions that can present with deep lung infections can resemble squamous cell carcinoma. So a biopsy and microscopy are required for diagnosis. If they turn out to be fungal in nature, they are treated with antifungal medications. For us, when we see these types of lesions clinically, thank goodness we do not have to try to guess what they are. We get to just refer them out to the oral surgeon and let them do their work. Phycomycosis. It is a rare fungal infection found in the soil. It rarely causes disease, but it can cause infection in those immunocompromised patients. So this disease involves the nasal cavity, the maxillary sinus, the hard palate, and it can present as a very destructive mass. Obviously, if we saw something like this, we would refer the patient and a biopsy is required for diagnosis. There are many drugs that are used to fight fungal infections, and this isn't something that's covered in your book, but I think it's very important for you to be familiar with. You'll probably learn about this in pharmacology class, but here's a great introduction. There's a particular antifungal that is most commonly used in dentistry. It can be dispensed as a mouth rinse or a lozenge. So here's your first submission question, and you may have to do a little Googling, a little digging to find out the answer. What is the antifungal that is commonly used in dentistry? What is the antifungal commonly used in dentistry? I'll take a name brand or a generic brand. Okay, that is going to be it for part 1. Your second lecture submission will be included in part 2. As always, you can email me if you have any questions, and don't forget to like and comment on my video.